Okay, physiologic changes of pregnancy. As the baby begins to grow, the body's going to make all kinds of big changes, okay? And when they come to each visit, the provider is going to start measuring and making sure that the pregnancy is growing according to how it should, okay? Why is it so Quizlet? I'm not sure how to get this up. Oh, there we go. Okay. So we all learned in repro that the uterus is in the pelvis, right? And as the pregnancy grows, at about 12 weeks, it is now considered an abdominal organ, okay? The fundus, or the top of the uterus, can be palpated halfway between the pubic symphysis, right here, and the belly button, the umbilicus. The fundus should be palpated right at the umbilicus. Start measuring. So they'll lay the mama flat, and they'll take a tape measure. 0 inches would go right on the pubic symphysis, and they're going to have it on the centimeter side. And then they'll stretch the tape all the way to the fundus, and at 20 weeks, it should match about 20 centimeters. 24 weeks should be about 24 centimeters. And so that's how they can tell non-invasively how well that pregnancy is growing, just like a quick check. Okay. All the way up to 36 weeks to the xiphoid process. And then look here, it's 3 weeks. Why do you think that is? Yeah, because the baby's dropping down into the pelvis in preparation for birth, right? So after 36 weeks, it's not as accurate because baby's now starting to get ready for birth, okay? And if you guys turn, oh, actually, let me show you these couple slides first. So as you can see, we have 12 weeks, 20 weeks, we're getting larger and larger, right? The belly's starting to push out farther. The back, the spine is starting to curve, creating lordosis. You guys know this is the only time lordosis is normal, is with pregnancy, so that the body can compensate with all that forward weight, okay? All of the abdominal organs are now starting to get squished aside. The stomach will be compressed, the liver will be pushed up, the bowels will be pushed off to the side, making it more likely for constipation. So we want to encourage fluid, right? Mm-hmm. The diaphragm will also be pushed up, and where the diaphragm meets the esophageal sphincter, that gets pushed up. And because the esophageal sphincter no longer has the pressure of the diaphragm, it starts to relax, and that's what causes heartburn in a pregnant woman. That's normal. Heartburn is normal. Okay. It's not because the baby has a lot of hair, that old wives' tale, right? It's because that esophageal sphincter is not at the diaphragm anymore, causing it to relax. Okay. As that belly grows, we start to have what's called supine hypotension. Because when a mama is flat on her back, the uterus will start to push on the aorta and the vena cava. Okay, so after 20 weeks, we never want a mama to lay flat on her back. We always want to tip her, either just a little tip or all the way on her side, to get her off of those vessels, because those vessels supply the lower legs and also supply the uterus. Okay, so if she's flat on her back, we're reducing blood flow through the placenta and reducing oxygen to the baby. So we always want to have that mama at least tipped to one side. Noting here that the vena cava is more to the right, than the mama's left. or in the middle, right? And so the best and most preferred side is the left side. I'm going to place her on her left side, okay, to get the pressure off. Now, can we put her on her right side? Absolutely. She's not flat on her back, but the best and most preferred side is the left side. If you see that on a question, which side are you going to put her on? Her left side, right? And so that's why we put her on her left side. If she were to be flat on her back and she were to sit up right away, she's going to drop her blood pressure, causing supine hypotension. She'll have dizziness, sweating, and not feel good, maybe some vomiting, nausea, okay? So we always want to put them on their side, specifically the left side. The maternal body is going to adapt significantly as the pregnancy progresses. And you guys have a little cheat sheet. It looks like this in your lab book. So if you could turn to that. That way you're not like crazily writing as I go through these big things that happen, okay? You guys have that as a visual to study off of. You can take notes on this as I go through it. Kind of like almost to the middle. I think you even have a digital version of that, but I like to print it out for you. Okay, so starting with the cardiovascular system, the maternal blood, in order to support that pregnancy, is going to increase in volume by 40 to 45%. So big increase in blood volume. And that increase in blood volume is mostly blood plasma, okay? And not as much red blood cells. So that makes their H&H, their hemoglobin and hematocrit, diluted. And so a lower hemoglobin and hematocrit is normal in pregnancy. We don't consider it, it's called pseudoanemia. Okay, we don't consider a pregnant woman to be anemic until her hematocrit is below 11. Okay. When you think about the cardiovascular system and we're increasing by 40 to 45% blood volume, what do we think that does to the heart? It makes it work more, right? And because it's working more, it's going to start getting bigger. It'll expand. And we might get some heart murmurs, okay, because it's expanded. And so heart murmurs are normal in pregnancy because of that increased blood volume.
They still refer you to a cardiologist, do they?
No, it's normal.
They did to my sister.
Maybe she had something else going on too.
No, she's never had anything before. And then for the baby girl she just had, they sent her for a cardiologist. And after the pregnancy, she went to see the cardiologist again, and the cardiologist was like, "Oh, you're fine."
Yeah, it's normal. So I'm not sure why they did that. They might also have some palpitations, again, from the from the heart enlarging. They'll also have some hypercoagulability due to increased clotting factors. And increased estrogen levels. Estrogen puts us at risk, right? We learned that for DVTs. And so pregnant women are also at risk for DVTs, not only because of the hypercoagulability, but because they have decreased blood return from the lower extremities. In the GI system, the increasing HCG levels can cause a pregnant person to become have nausea and vomiting, especially in the first trimester, as they start to get used to those HCG levels. And eating frequent meals, small frequent meals throughout the day, helps reduce the nausea and vomiting. Bless you. So know that. Eating small frequent meals helps reduce nausea and vomiting in the first trimester. The gums will become tender and may bleed easily. We talked about those intestines get displaced. We talked about that esophageal sphincter relaxing, causing heartburn and reflux. All these things are normal. Progesterone will also cause decreased stasis of the gallbladder, which increases risk of gallstones. For the endocrine system, the placenta will produce many hormones for retention of the pregnancy and fetal growth. We'll talk about those hormones. I kind of break it down throughout the class. The thyroid will increase in size and activity, and also the parathyroid. The pituitary gland will enlarge in the 9th month and start to produce FSH and LH. Some other hormones, but also prolactin. Prolactin is our lactation hormone. The respiratory system, the nasal lining will become fragile, causing nosebleeds. Sometimes they'll get congested. We think that's because of the estrogen. As the uterus enlarges, it also puts pressure on our lungs. So they're going to have an increased respiratory rate because they need more oxygen. So their respiratory rate is usually 20 to 26 is normal. Okay. You might be short of breath too because of that pressure on the lungs. Psychosocial adaptation, there's a few slides on that, so I'm going to skip over, but we go through different phases of pregnancy acceptance. The skin, the integumentary system, will go through different changes. We'll have hyperskin pigmentation, specifically creating a line from the pubic symphysis all the way to the top of the abdomen. This is called the linea nigra. The nipples will start to darken, and the face will start to darken. That's called melasma or facial mask. And those three things work together for breastfeeding. So when baby's born, baby's placed on the abdomen, it can see that line because it's nice and dark. So it will start, has a crawling reflex. It'll start crawling, following that line, looking for and bobbing its little head for the dark areola, the nipple. And it will start grasping. It has a grasp reflex as well, so grasping at the breast, stimulating the breast, and it starts salivating. The nipple will also release a scent that's similar to amniotic fluid, so the babies can smell that, so they can reach the nipple. They can latch themselves without you even doing anything within about 10 to 30 minutes after birth. Once they've latched themselves, it's called the breast crawl. Once they've latched themselves, They'll then look at that darkened face on the mother and stare into their eyes for bonding. And so that's what all of that's all about. I have a video on the breast crawl coming up for you guys. She might get some acne, and some spider nevi in the legs, and then stretch marks. Okay, as the skin expands. Stretch marks are genetic. Thank you to your parents. No amount of lotions and potions and all kinds of things that you put on your abdomen is going to reduce stretch marks. It's genetic. We talked about, for musculoskeletal, we talked about that lordosis to support the weight. You're going to have an altered center of gravity, and they might waddle when they walk. Okay. The placenta will also produce another hormone called relaxin. Relaxin does what it says it does. It relaxes. It relaxes the ligaments and the muscles, and the cartilage in the pelvis, so that we can open up the pelvis for birth. Okay, open up the legs for birth. So relaxin can also cause leg cramping in the third trimester. Okay. You have 2 slides on leg cramps, because after my first class I was teaching here, I noticed on the HESI that a lot of students were missing the leg cramps question, so I threw in more info on leg cramps. Leg cramps are common in the 2nd and 3rd trimester because of increased weight and pressure, maybe some electrolyte imbalances going on, and poor circulation. Symptoms: sharp, sudden pain, usually in the calf, and it's usually at nighttime. What do we do to prevent leg cramps? We make sure she stays really hydrated. We teach her to do stretching exercises before bed. Keep up with her regular exercise routine. Wear supportive footwear. She can use warm compresses on her calves and keep her legs elevated at night. Nursing interventions, mostly patient education. We're going to teach them all of those things, increasing calcium and magnesium in their diet. In pregnancy, we always want to try non-pharmacological methods first. Okay, so we'll try all of those things first. And then if it's severe, the provider is going to order calcium and magnesium supplements. There's your printed picture you already have. And here's a video on the breast crawl. I'm going to fast forward through some of this stuff that you don't need to listen to.
With a warm cloth. Baby is very alert soon after delivery and hence is at its instinctive best. Baby is also kept warm, being in close contact with the mother. Baby is also prevented from future infections because she starts acquiring healthy germs, which will
put it in another order. It worked the other day.
Thus, this position ensures early instinctive stimulation.
Yep, that baby was just born and placed on mom's abdomen. I'll just talk over her since we can't hear.
Bonding process between the baby and the mother.
Baby's using that crawl reflex to get up to the breast. Okay. As the baby kicks, it's also massaging the fundus for mom, so mama doesn't bleed too much. Okay. So this is the best place for both mama and baby right after birth because they transition the best together. We shouldn't ever separate them.
This will help to expel placenta and reduce bleeding.
Baby's grasping that breast
Once
tissue.
baby realizes that
and
food is in
stimulating
close
the breast,
proximity, it starts salivating.
starts to salivate.
Smell is a strong stimulus which drives the baby towards the nipple. Baby's smell sensation is well developed. Smell of a chemical on nipples is similar to the smell of a chemical in amniotic
I don't think you guys
which
saw it in
surrounds
the
the
beginning, but
baby
in a
in the
minute
womb.
you'll see. She's outside in a warm environment. Yeah, and there's a bunch of family around. But this, if she were inside and there's air conditioning, for sure she would cover that baby. Almost.
Her shoulder, hip, and neck muscles are sufficiently developed to help her move. Baby with her limited vision can see the areola.
There you go.
If baby raises her head, it can also see mother's face.
Right?
Baby has reached the nipple, has raised her head, and has nicely lashed it with wide open mouth and mouthful of breast. What a beautiful moment of joy for the mother and the child. This baby has reached the destination in just over 10 minutes. Majority
She
of
said that the
babies
baby
successfully
reached the breast
complete
in
breast
just under
crawl
10
in about
minutes
30
for this
to 60
one.
minutes. Like all other gifts of nature, this comes free of cost. However, the health and nutrition benefits offered will save millions of lives.
If you download the video from the PowerPoint, you should be able to hear what she's talking about. But that is the breast crawl. Social changes, psychological changes during pregnancy. And this goes for both partners. Okay. They'll go through mixed feelings earlier in pregnancy. And then mama's going to start to become introverted. She'll turn inward, thinking more about her pregnancy and protecting that baby. And then she's going to have acceptance, where she starts to identify with the role of motherhood. She might have some changes in her emotional state. Those are normal. She might be totally happy one minute and the next minute she's crying. And that's just a lot of the hormones that are going on. I remember when I was pregnant with my daughter, we had a party, and my brother-in-law had drank all of the Sprite. Oh. And I really wanted some Sprite. And I didn't know he drank it all, so I went to go get the Sprite. And I just started sobbing because there was no Sprite left. So of course my husband jumped in the car and went and got me some Sprite so I could stop crying. Robin.
I have just a funny quick story. My sister, when she was pregnant, we went to Taco Bell. She was craving a Mexican pizza. We get out of the car and she dropped it, and she literally just started, like, she just broke down. We couldn't console her. Like, it's okay, we'll get you an Elma. She's like, why Mexican pizza? It's okay.
Yes, yeah. Just little things can trigger it. And then they might have some body image changes because their body's going through a lot, right? They might be good feelings or negative feelings. Like, I am not a cute pregnant person, you guys. I get the big swollen nose, and I just look like a round ball. I'm not cute. So positive or negative changes there. We talked about a lot of, I skipped a slide, sorry. Maternal psychological changes. So this just brings it down to for trimester, that last slide. So in the first trimester, we're going to accept the pregnancy, both partners. Okay. Acceptance second trimester, acceptance of the baby. And in the third trimester, we're preparing for parenthood. We talked about a lot of different things that happen, right? But I really want you to know these danger signs. Danger signs of pregnancy. And this can be at any time. Fever over 100.4 makes that baby cook warmer, right? 100.4 Fahrenheit or 38.0 Celsius is fever. We would want to bring down that fever, okay? After 20 weeks pregnant, we can only use Tylenol. You know, there's a lot of controversy about Tylenol, but it's risk versus benefit, right? If mama has a fever, we need to use it, let's use it, okay? We do not do ibuprofen after 20 weeks because it messes with the fetal circulation. We'll talk about fetal circulation later on. And so we can't use ibuprofen. It closes one of the shunts in the heart.
But you can do it before 20 weeks?
Uh-huh.
You can use it?
Yes.
You can use the Tylenol, right?
Tylenol after 20 weeks. No ibuprofen.
No.
4 are all signs of preeclampsia. So we're going to monitor these signs in every patient every time we see them. We're going to ask them these questions. Do you have any severe headaches that doesn't go away with Tylenol? Are you having blurred vision or seeing stars or spots? Do you have any epigastric pain, specifically in your right upper quadrant where your liver is? Swelling in your hands or face? Those are all screening for preeclampsia. You guys have a full lecture on it.
In the upper right?
Upper right quadrant where the liver is. Vaginal bleeding is never normal in pregnancy, so we would want them to get seen for that. We all know burning when you pee is a sign of a UTI, so we would want to get seen for that. Any gush or continuous leaking of fluid from the vagina, that could be the amniotic fluid coming out, we would want to get seen for that. Decreased fetal movement, so baby's not moving as much as it usually does. Okay. Once a day after 20 weeks, we educate our patients to count how much the baby's moving. We have them lay on their side. Which side? The left side. Drink a large glass of cold water, juice, and then start counting. We want them to have 10 movements. Doesn't have to be big movements, just any movement. 10 movements in 2 hours. If they don't get 10 movements in 2 hours, they need to get checked out and make sure that baby's doing okay. Of course, any signs of preterm labor, we would want them to get checked out.
10 movements per hour?
10 movements in 2 hours, yeah. Once they get to 10, they can stop counting. They don't have to go the whole 2 hours, but we want at least 10 movements in 2 hours. Let's see. We would just put the baby on the monitor and do some testing to make sure baby's doing okay. Bless you. Recommended weight gain during pregnancy. I'm going to blow this up for you guys to see. Normal weight gain on a person who is normal weight is 25 to 35 pounds. I want you to know that range, okay? 25 to 35 pounds is normal weight gain. If they're underweight, we want them to gain more. If they're overweight, we want them to gain less. And if they're obese, even less. Okay? But know that normal 25 to 35 pound range is what we want. We're going to teach them their nutritional requirements. We want to increase their calories by 300 calories per day when they're pregnant. It's not eating for two meals 3 times a day. Okay. Just 300 calories, which is like a light snack. That's it. That's all they need. If they're breastfeeding, they need 500 extra calories a day. They do need more with breastfeeding. We want them to increase their protein and their water intake. We want at least 8 glasses of water a day. More is always better. Okay. When a patient is dehydrated, we produce a hormone. What's the hormone called? When you're dehydrated. Antidiuretic hormone. Antidiuretic hormone. Huh? Antidiuretic hormone is similar in compilation to what we call oxytocin, which binds to the uterus and causes contractions to happen. And so if they're dehydrated, they're going to have contractions, and we want them to not have contractions, right, until we're ready. And so lots of water. If they have any caffeine or caffeinated beverages, we prefer them not to. But if they do, then they need to add 1 glass of water per beverage onto that. Okay. Because you know caffeine makes you dehydrated, right? And so the idea is like 1 cup of coffee or 1 can of soda, we add 1 extra glass of water. Then they need even more. Yeah. We're going to take prenatal vitamins. We're going to do folic acid or folate to prevent what? Neural tube defects. And iron. Iron is going to help with that pseudoanemia. Foods to avoid. We want them to avoid unwashed fruits and veggies, unpasteurized dairy products, raw eggs, raw anything, undercooked meats. We want them to avoid fish high in mercury. How do we know what a fish high in mercury is? It's the bigger fish. Because the bigger fish eat the littler fish, which increases their mercury. Okay, so avoid bigger fish. They need to also avoid lunch meats. Lunch meats have a bacteria called Listeria, and it's harmful. So no lunch meats.
Are those like from the cart?
Like deli meat. Yeah. You could cook it, yeah, and then eat it. Yeah. Yeah, how would you? Yeah. And then some women, I love bologna. I haven't had bologna in a long time. That's okay. Pica is something that pregnant women can get. Pica is craving of non-food items. Okay. Typically, it's laundry soap. Sometimes cornstarch. Sometimes dirt. But whenever we have a patient that says that they're craving non-food items, it usually means that they are anemic. So we should do a blood test. Okay. Stages of fetal development. When the sperm and the egg meet, it's called fertilization, right? And that happens where? In the fallopian tube. When the sperm and the egg combine, they create one cell. That's called a zygote. And then it's going to perform cleavage, where the one cell becomes two, two becomes four, four becomes six, and so on and so on. And then a little clump of cells is called a morula. Looks like this here in this screen. So we have our fertilized egg creating a zygote. Then 2 cells, 4 cells, 8 cells. Big clump of cells is morula. And then we have a blastocyst. Blastocyst is about day 4 through 6, and so on. And eventually that blastocyst will implant into the uterine lining, into that endometrium. If you look at this blastocyst here, you can see, go over there, this little lump here, that little pink lump, that's going to be the fetus. This is the amniotic fluid. This will be the amniotic membranes or amniotic sac. Right here, this yellow underneath the fetus is the trifectoderm. That'll become the placenta. The embryonic stage is 2 weeks after fertilization through the end of the 8th week of pregnancy. It's called embryonic stage because it's not using the placenta to survive at this point. It's using what's called a yolk sac, which is inside that's helping the baby with the fetus with the nutrients. Okay. The fetal stage begins during the 9th week of pregnancy, where the placenta starts to take over and giving the nutrients to the fetus and nourishing the fetus, producing hormones. It'll start to produce its own HCG and estrogen and progesterone. Yeah.
What does it feed on in the embryonic?
The yolk sac.
Yolk?
Mm-hmm. Yolk sac, like an egg.
Okay.
Yep. Yeah. Hormones. Mm-hmm. Lots.
Okay.
But
I thought there was one in particular.
to sustain and nourish the fetus, yeah.
Okay.
We'll talk more about the hormones. An ectopic pregnancy is a pregnancy that implants anywhere outside of the endometrial lining of the uterus. Okay, anywhere. Most commonly it happens in the fallopian tube because that's where fertilization occurs, right? And so sometimes if there's some scar tissue from a previous surgery or trauma or even PID, pelvic inflammatory disease, that embryo can get stuck in the fallopian tube and it'll implant itself in there. Or also called a tubal pregnancy. If this fallopian tube ruptures as that embryo starts to enlarge, that is a life-threatening emergency. She has to go back to the OR right now. We're not going to put in an IV. We're not going to give her oxygen. We're rushing her to the OR to save her life. Okay? Once we get her in the OR, then the whole team is going to help put the IV in, get her under, give her oxygen, all of that stuff. But we've got to, don't pass go, you go straight to the OR if we suspect a ruptured ectopic pregnancy.
Do those pregnancies actually go through? Is there liable?
If it's in the fallopian tube, it can't. We have to terminate that pregnancy.
There's no way for it to come down?
Mm-hmm. It's stuck. Yeah. It starts to grow and it just can't get through.
Been there for a while.
Yes. So if we suspect a tubal pregnancy and it's not ruptured yet, we're going to give what's called methotrexate. You guys have heard of methotrexate, right? Methotrexate is a chemo a cancer drug, a chemo, and that's going to attack rapidly growing cells like cancer, right? An embryo is rapidly growing cells, and it's going to terminate that pregnancy so that she doesn't end up with a ruptured ectopic pregnancy. Okay. Less commonly, the embryo will implant somewhere else. It could be on top of the uterus, it could be in the cervix, it could be on the bowel, it could be on the liver even. And those we would want to terminate as well. Okay, yeah.
So when they I'm sorry, this one I've seen videos too, and there's like young girls who get pregnant. I guess it's called the pregnancy. But do you really determine, like, does it depend how far you are?
It's recommended that it's terminated because the life of the mother is at risk. Okay. Now, I did have one patient one time whose pregnancy implanted on her liver, and she was told that she should terminate, and she decided she did not want to. Okay. So she wanted to carry that pregnancy as long as possible, whether it resulted in a live birth or not. Okay, so they watched her very closely. And she ended up making it to 32 weeks, and we did a C-section to have her baby. Before her C-section, we had all the blood in the OR. We had all the teams there, GI, everybody was there ready to help save her life once we delivered that placenta off of the liver. And it ended up being that that mama and baby were just fine. She didn't need blood. Crazy.
Some things happen like that.
Some things happen, right? And so it's very rare, but it is possible. So she chose to give it a shot. I went through all of that good stuff. Okay. The embryo implanted on the liver. Somehow an egg and a sperm got out of the fluid. And floated around. They got decided the liver sounded good. Okay. Yeah. Absorb. No, it'll absorb. And then we just watch that mama really close to make sure her levels will come back down and all of that. And after methotrexate, we tell them not to get pregnant for 3 months to make sure it's all out of her system before. Twins happen. Twins or multifetal pregnancy. Remember when the sperm and the egg create one cell called a zygote? Okay. So identical twins are monozygotic, meaning it came from one fertilized egg. Okay. Fraternal twins are dizygotic, di referring to two, zygotes, two fertilized eggs. Okay. And how we determine risk of identical twins determines when that egg split. Okay, so identical twins coming from one zygote, that egg will separate into two. One egg becomes two embryos. Okay. If it separates before implanting into the uterine lining, we will have two babies, two amniotic sacs, and two placentas. So everything will be doubled. Okay. If it splits after it's implanted, then we could have twins with their own sac, but they're sharing a placenta. And that's higher risk because one baby could take more nutrition and oxygen from the other. Not on purpose, they're not rude. It might happen. Okay, so higher risk there. So when we have them here with 2 and 2, we have di referring to 2, amniotic, amniotic sacs, cozy homes. Okay. Or if it's sharing a placenta, we have diamniotic, 2 amniotic sacs, and monochorionic, referring to the placenta, sharing one placenta. If it's that's even later, then we might share both. Monoamniotic, monochorionic, sharing a sac and a placenta. That's even higher risk because they can tangle each other up in their cords. Okay. Yeah, so if it's even later than that, that's where we get our conjoined twins.
Yes.
Yeah. Yeah, usually triplets and quadruplets are fraternal somehow, or sometimes you could have an identical set and then fraternal other set. Just depends. Yeah.
So knowing the risks and take them out the whole time, C-section, I'm gonna get them out.
Get out the multiples.
Yeah,
Monitor these babies closely
okay.
to see if one's taking some from the other. And we could transfuse one of the babies if we needed to in utero. Give them some blood transfusion. These ones, the di, sometimes we don't know that they're identical until the birth. Okay, because fraternal twins would have 2 of their own things, right? Sometimes we don't know that they're identical until we see them. And then I wanted to say, I think.
When one is hiding behind the other, they don't know that you have twins.
Sometimes they do hide, yeah. Usually it's picked up after you have more ultrasounds. Yeah. Yeah. Remember, it's better for our bodies just to have one pregnancy, one fetus at a time, because that's where we do better. Mama and baby are at more risk with each fetus that's on board, so the risk increases. Typically, they say twins usually go to about 38 weeks, triplets 36 weeks, and you lose a couple weeks per baby that's in there. Now to pregnancy. In the first trimester, that's weeks 1 through 13 of pregnancy. The second trimester begins at week 14 through 26, and then the third is weeks 27 through 40. In the first trimester, like I said before, the mom is starting to adapt to that HCG in her blood, so they're going to have nausea, maybe some vomiting, and urinary frequency from that fetus pushing on the bladder. In the second trimester, they're going to have relief of symptoms like that. They call that the honeymoon phase of pregnancy, where they're feeling really good. Okay, baby's off the bladder now because it's above the pelvis. They've started to adapt to that HCG. That's the honeymoon phase. In the third trimester, then they start to get more uncomfortable as that belly grows. Baby's going to drop back down into the pelvis, pushing back on the bladder, causing more urinary frequency again. Here's a video on fetal development. You know what? I'm going to, since it's not working, I'm going to let you guys watch that one on your own. Video. Looking at the anatomy of the pregnancy, we have the amniotic sac, which surrounds, comes off of the placenta and surrounds the fetus. The amniotic sac, where's my placenta? Here it is. The amniotic sac has 2 parts. The one that's closest to the uterus is called the chorion, and the one that's closest to the fetus is called the amnion. Kind of like when we're talking about monoamniotic and chorionic, right? Chorion closest to the uterus, amnion closest to the fetus. Okay, two membranes, we call it.
So amnion is fluid.
Yep. The amniotic fluid does all kinds of cool things. It works as protection to help absorb any shock to the abdomen. Helps protect that fetus. It helps the fetus regulate its temperature. It allows unrestricted movement. And it helps with symmetrical growth. The placenta is really cool as well. It sustains and nourishes the growing pregnancy. It transfers and exchanges substances, so brings nourishment and also takes away all of the waste. And it acts as a barrier to certain substances. Some things cross the placenta where others don't. Like if we're talking about STIs, gonorrhea and chlamydia don't cross the placenta, but syphilis does. HIV doesn't cross the placenta. So some things are stopped to protect that fetus. And it also functions as an endocrine gland, producing that estrogen, progesterone, HCG. Human placental lactogen, which you guys will learn about when we talk about gestational diabetes, and relaxin, that relaxin hormone. The side that touches attaches to the uterus looks very beefy, like ground beef here. And this one's starting to calcify in this image here. See those? Calcifications. So we were probably a little bit past the due date in that one. And then the other side, the fetal side, is very shiny. It's very vascular. You'll see lots of vessels everywhere. And that's where the umbilical cord is attached to. If you can see here, look at this one. We have 2 sacs and 2 umbilical cords. So this one, twins, shared a placenta, but they had their own sacs. We learned in semester 1 that mom and baby's bloods don't mix, right? Remember? Mom and baby's bloods don't mix. What happens is that the maternal blood pools in the placenta, and the fetus's capillaries go into that pool. Okay, it's exactly like hydroponics, where we would grow plants without soil. In this image here, they would have nutrient-rich water here, and the roots of the plant go into that nutrient-rich water and exchange waste and nutrients. Okay, so that's how the placenta works. It's really cool. Then we have our umbilical cord. Our umbilical cord should have 3 vessels. We call it ava, 2 arteries and 1 vein. Okay. The arteries carry waste away from the fetus, and the vein takes oxygen and nutrients to the fetus. It's opposite ours, right? Yeah, so arteries, remember, arteries away from the fetus, and then the vein carries oxygen to the fetus. Coil, this is actually a really good one here, and that helps protect it from pinching or cutting off the circulation for the baby. And it also has what's called Wharton's jelly. Wharton's jelly is gelatinous material that also helps protect those vessels from getting pinched. Wharton's jelly is really cool, that when that cord hits the cold air after birth, it starts to expand and it will actually clamp those vessels off all by itself. We wouldn't have to clamp and cut this cord. We would eventually, the Wharton's jelly will expand so much that it cuts off those vessels. Pretty cool, right? This is just another picture showing you those 2 arteries in one vein and all the little capillaries exchanging nutrients and waste. Another video I'm going to let you watch on your own. This is fetal circulation. Because the fetus isn't using the lungs in utero, it's using the placenta, right? We have 3 different shunts that help shunt the blood away from the lungs because we don't want it to use the lungs in utero. Okay, so watch the video just so you kind of understand it a little bit better. But I really want you to know the 3 different shunts. Okay, there's the ductus venosus, which shunts blood away from the liver in utero. The ductus arteriosus, which is in the aorta here, reducing the pressure to the lungs. So some blood will go to the lungs to grow it, but we don't want to use those lungs, so it'll go away from them. And then the foramen ovale is the hole in between the 2 atria of the heart. The foramen ovale shunts the blood back and forth, again, reducing the pressure in the lungs so that we don't need to use it. Okay. Once the umbilical cord is clamped, that will start increasing baby's blood pressure, which will start closing off those shunts so that the pressure increases in the lungs and the baby starts to use the lungs to breathe. Okay. So know those 3. The foramen ovale is the shunt that is involved if the person takes ibuprofen after 20 weeks. So it'll close that hole in the heart and increase the pressure to the lungs, and the baby starts using the lungs in utero. And that's why we don't want them to use ibuprofen after 20 weeks. The fetus would die. Yeah. Mm-hmm.